Yeah, so scan it and ask questions, or if you want to just stand and ask, I just have some here. So, um, the first one is for Jessica. For FLNC, what criteria do you use to recommend prophylactic AICD?
Uh, for FLNC, so the evidence is emerging, so it will probably follow. Is it on? Can you hear me okay? No? Okay. Sorry. So, fine, ask. Okay, so there's no clear guidelines yet, but of the sort of RBM20, they're following the LMNA path, and so it's going to be EF less than 40 or so. And then there's some additional risk factors.
Other questions?
Oh, sorry, EF less than 45.
Okay, so I think then I should be asking the question. So maybe I'll first ask Bob. Bob, how exactly would you be deciding, specifically when you have hypercholesterolemia and the triglycerides also are up, and in other case the triglycerides are not up? So for the common practice knowledge, where would you go? I mean, like, do you think that the ANG-PLT3 would be going on one side versus the PCSK9, or how exactly would you give some kind of guidelines to people so as to at least start thinking about it when these agents are coming?
When we consider triglycerides in the fasting state, when the triglyceride levels are 880 or 10 millimole per liter or higher, US may state 500 milligram per deciliter or higher, the risk of acute pancreatitis increases. Once you've had an episode of acute pancreatitis, the likelihood of having a recurrent episode increases 23-fold. And if you've had one or two or more episodes in the preceding year, the likelihood of another one is increased 43-fold. You're focusing on lowering triglycerides. What's not often understood is that dietary fat increases chylomicrons. It's not refined carbohydrates. Refined carbohydrates affect VLDL production. When the triglyceride levels are less than 880, less than 500, we have no evidence that lowering triglycerides reduces atherosclerotic cardiovascular events. We can't state that the icosapent ethyl study is proof of concept because the triglyceride lowering was marginal and the reduction in cardiovascular events was unrelated to the triglycerides. Why might this be the case? We're going to learn at AHA the results of the prominent trial, which evaluated individuals with high triglyceride and low HDL cholesterol that post hoc subgroup analysis identified as potentially achieving an event reduction with fibrates or PPAR alpha agonists. This is a selective PPAR alpha agonist. The study was terminated due to futility, and it may be, at least from prior studies with that agent, a lack of change in apolipoprotein B. We'll see what happens when the data is presented by Aruna Pradham at the AHA. So why does ANG-PTL3 different? Because it lowers triglycerides perhaps more by 60 to 80% based on the inclusion criteria for the triglycerides, but it also reduces apolipoprotein B. And the key issue, if you want to reduce risk, is lowering the concentration of atherogenic lipoproteins. And this is, I think, a major paradigm shift forthcoming. American Heart Association presentations will guide those next steps.
Thank you. So, I mean, like, let me make it a little more common problem. 500 triglycerides and all are understandable. But say a patient with coronary artery disease, the patient has had a PCI in past, is, with the maximum statins, the cholesterol level, LDL cholesterol is still 120 or 110 for that matter. But triglycerides are 250 or 300. Hypothetically, if I had availability of both evinacumab as well as alirocumab, which one am I going for?
Oh, an ANGPTL3 inhibitor, without a doubt, is more effective in lowering triglycerides. In a pooled analysis of volocumab, I had reported before that 14% reduction in triglycerides. So you're talking about 14% versus 50 to 60% reduction in triglycerides. So I think on that point, and also the ANGPTL3 inhibitors are far more effective at lowering the non-HDL cholesterol because it's affecting, the VLDL, the remnant, particles. But until evinacumab is approved for that indication, the PCSK9 inhibitors will reduce the concentration of the ApoB particles, which are cleared by the LDL receptor. So, that would be an approach. And I think one other point I'm just going to comment for the purpose of, education is that moderate to high doses of statins are very effective at lowering triglycerides. They lower it by 40%. It may actually, be better than a, fibrate or an, omega-3 fatty acid. That's often missed, and the efficacy of the high-dose statins works up to 880, before you get to chylomicrons. So don't forget about high-dose, high-intensity statins as your first-line therapy for treating patients with mixed hyperlipidemia short of the chylomicrons.
Thank you. Dr. Wilson, what do you think is now going to be the role of telemedicine? I mean, you showed a beautiful slide there that we have now come down to like about 30% now, as compared to what we peaked to about 70% during the pandemic. So do you think that it is going to stay? Are we going to bring this into our practice? Would there be more use of telemedicine? And is it going to really help throughput?
Yeah, that's a great question. Thank you, Dr. Narula. So I think all of us know or feel that, it's probably a lot less than 30% now. And probably as I go around, more like 5 or 10% at most that people are using telemedicine. But I think the one thing about COVID-19 and what we went through, if we forget the lessons we learned there, that would be a real failure. And I think it did show us that telemedicine can be effective, and so that we should not completely let telemedicine die out, but we should actually look at ways in which we can continue to utilize that, particularly as we look at wearables and other remote monitoring devices, sometimes in remote locations or in patients who have less access to care, even in cities, that we can use telemedicine to help take care of these patients so that they don't end up in an acute setting or end up, again, having to go to emergency departments and hospitalizations that might have been prevented if there had been some stepwise care along the way. So again, I think if we let go of telemedicine, that will be a huge failure from what we've learned through the pandemic. And hopefully we will continue to incorporate telemedicine as a pathway for care, and perhaps even have that curve go back up again to a certain level, maybe 20 or 30%, or maybe even more in that chronic disease category, so that we're really just doing acute care and not doing well care with our telemedicine, although it should be able to alert us when the patient needs to seek a higher level of care. So hopefully we can use that as we go forward, and we can use telemedicine to our advantage and to our patients' advantage, and really have a new paradigm of transform of care.
So thank you. And then what was the role of, and you showed one of the beautiful pictures there, that when we can dispatch the vans and things like that, what would be the complementary role of them? I mean, would it be that they would be providing us the examination, or would we be getting the investigations done at home, or like how can it complement the telemedicine? I mean, can it really compensate for the lack of our interaction with the patients?
Well, of course, I never want to separate ourselves, our care team, from our patients. Patients are foremost. But in that example, and I didn't explain that fully, but the dispatch unit actually then communicates with, medical professionals of the team or cardiologists at the center and they can do all that needs to be done in the evaluation similar to an urgent care in the home. And then they can determine whether or not that patient can be treated in the home, with the telemedicine, with the higher level of provider, but also then whether or not that patient truly needs to be transported to an emergency department. But it's been shown in small numbers that they can actually keep more of the patients at home rather than having them seek higher level of care in a center.
Thank you. Question for Dr. Wang. There's a distinct difference in the arrhythmogenicity in dilated cardiomyopathy in various type of cardiomyopathies. For example, those dependent upon lamin versus dependent upon dystrophin. So say the person has lamin defect, but is relatively mildly reduced ejection fraction. Would you change your indications for ICDs in those cases as compared to a person having dystrophin type of cardiomyopathy?
Yeah, so I think based on guidelines, I think lamin is
I
one
can't
of the,
hear you.
based on
Yeah.
guidelines, lamin is one of the genes identified to be more highly arrhythmogenic, and so the EF threshold is higher. And I guess EF also does not account for the amount of fibrosis in the heart. From truncation FLNC research, it's basically by the age of 40, it looks like about 90% of FLNC truncation variant carriers have some kind of manifestation. Many of them, about 50 of them, have evidence of scar on MRI that is not, evident on echocardiogram. And so there's some additional risks other than EF. But I think overall, the risk of arrhythmia is still lower, progressively lower in people with lower ejection fraction versus people with sort of preserved ejection fraction. So there's a gradient between, even among patients with scars. And so I think in the future, we'll have more defined risk calculators in putting all these together. But overall, the EF threshold, currently we're going by EF threshold in implanting ICD sooner, maybe as they dip at around 45 or so. And that is different from the general DCM population. But I think there's going to be more work going into specific genes. So RBM20, LMNA, are all these genes that are thought to be arrhythmogenic DCM genes. I think, the tools now are pretty rough.
Right.
So in the future.
So the next one was for you, but I think I would rather pose it to Dr. Wilson. The question is, when do you think genetics is going to become the mainstream, and when would we be able to get the approvals for the genetic testing for our patients?
Oh, I'm not sure I can answer that. I think Dr. Wang, I'm sorry, I'll pivot.
Sure, yeah. On the practical level, a lot of companies now offer self-pay at $250. So it's pretty affordable. And they're sponsored testing. So for companies that make TTR silencer, TTR stabilizer, they sponsor these testings for HCM indication. And then for DCM, not as much sponsor, but there's ways you can get things sponsored. And so these investment dollars into new drug development, they paid genetic testing companies to help get the genetic diagnostics done so that patients can be identified. Then eventually these patients will benefit from these drugs. And so there's investment through that. And so that's under sponsored testing. Private insurance can cover nowadays. Oftentimes they will cover. And then Medicaid, Medi-Cal, it's interesting. I think for oncology, Medicare does cover, but for cardiology, it may not be so. So for the genetic testing services, in general, the out-of-pocket for patients has been $0. They just somehow they work it through.
Yeah, you would need Dr. Wilson's help there to get this through. That's why I wanted to ask that
I will
question
need
from
your
him
help too.
more than.
Yes, sir.
So the next one is to Bob. It says that what is the role of CRP in the treatment of cholesterol? What about a patient with LDL at goal, but CRP is still being high?
CRP is a risk CRP is a risk marker for cardiovascular risk. It's not in the causal pathway for cardiovascular disease. Perhaps interleukin-6 is, which is the cytokine that sends a signal to the liver. There are many different therapies that are being developed to reduce inflammatory risk. One of the ones that has stood the test of time is colchicine in people with stable and acute coronary syndromes. It's a therapy that we're using in patients. We've optimized the lipids who keep rupturing plaques. So that's one possibility. There are also a lot of work looking at other inflammatory pathways and how that relates to inflammation. A lot of interest in let's say the lipoprotein A link, but this is certainly the next horizon in terms of preventive therapy. It's a very exciting time, but other than colchicine, there's nothing really available.
Right. And then the question was, what are the cytokines that are normally involved in the plaque inflammation?
So plaque inflammation, we're thinking about, the NFKB, pathway, interleukin-1 beta, or interleukin-6, in terms of, recruitment to the mononuclear cells. MCP1 is a target. TNF-alpha has a role. So there are multiple different cytokines that are involved, and usually there's a trigger in terms of oxidized phospholipids. Lipoprotein A is a major plasmatic transporter of oxidized phospholipids, which can set all these transcriptomic pathways, all these genetic pathways in motion. And that's going to be the focus of our late-breaking basic science presentation at AHA on Monday morning.
There is another one for you. What about lowering LP little a for aortic stenosis?
Genetically, there's a very strong relationship between LPA and aortic valve stenosis. There's been discussions about clinical trials to look at whether you can prevent progression of aortic valve stenosis, but nothing yet. The issue is, how much of the aortic valve stenosis is due to complete calcification of the valve, how much is due to inflammation lipids. In other words, what part is modifiable? How can we image the aortic valve to know who's a potential candidate for an LPA lowering therapy? I think these are a lot of the critical questions as the phase 3 studies are being designed.
Yeah, and it will all depend upon starting it early enough so that the calcification has not started to set in these cases, and possibly I think the role of geneticists will start to come more, and because there's obviously with the LPG gene, you basically have the significant association. That's the only one that stands out.
So in terms of genetics, isn't it perplexing that some patients with high LPA have aortic valve stenosis and not symptomatic coronary disease, and by the time angiography may not have flow-limiting stenosis, and other people with high LPA have coronary disease but no aortic valve stenosis. So we need to do a better job with our genetic testing, or looking at different SNPs that may be related to one disease manifestation versus another versus both, and make sure that we're targeting the right individuals. And certainly if they're at increased risk of aortic valve stenosis, we're going to be more aggressive in those patients with coronary disease. So there's a lot more to learn.
Thank you, because I'm getting the indications from Dr. Sharma that I have to stop the session. Oh, okay. Okay, because I thought you are nodding to me means I have to stop here.
We'll have a
So-
20-minute break after
Okay.
the question, but all the questions that have been asked, we need to answer. If they come on
Yeah,
the-
they're all here. I've taken care of all, essentially. Dr. Harpawat.
I have a question. On CCTA, is it as useful with your 3D analysis in calcified coronary artery as compared to non-calcified?
So, very good question. It is much better in terms of helping to characterize those lesions which are calcified when we use the FFR tools. So we are able to identify the significant stenosis. But if there is too much of calcification, I don't think that the CT angiography would be helpful there. And I know why you are asking that, but definitely in such situations, because you had, because I know some of your patients which you showed 3,600 CT angios and all, the calcification scores. Obviously, there it probably would be. No. I mean, there are multiple tools which have now come in, which are able to play around and give you better images. Neither they help nor the FFR will help when there is so much of calcification. And we also must realize that when the calcification goes to that extent, possibility also could be that this is the medial calcification and not the nodular calcification which is in the coronary vasculature. And there we would require the invasive coronary angiograms or
In your experience, how does calcification score relates with clinical events? Because normally it is predictability is only about 40%.
yeah. So as far as the calcium, see, calcium has multiple roles to play. And we had one of the editorial that we had written, is it predictive, preventive, or punitive? Right? So there are all three which it is. For example, is it predictive? So there is a generalized feeling that more the calcification, more is likelihood of having an event, because it tells you that there is presence of atherosclerosis. Number one. Now, is it protective or preventive? So if there is a significant calcification in a lesion, normally it prevents the likelihood of having an event because it has stabilized the plaque, right? Because there's a burnt out plaque. And then there is a third thing, which is is it punitive? So there are two ways of this being punitive also. One is that the spotty calcifications. If you have a thin fibrous cap and there are spotty calcifications there, they are like fulcrum, and they are stabilizing points, but then in between there is a fibrous cap. If there is a hemodynamic perturbation, those areas they hold it. In between there is a fibrous cap, it moves like that, cap ruptures and the event occurs. So this could be punitive in that way. And then the last important way of being punitive is that whenever there is a nodule sitting there, specifically when you have a nodule which is sitting in a huge necrotic core, that too at a bend of an artery, wherever you have, say, tortuous artery, that too at the areas of the heart where the artery is significantly turning, like in the right coronary artery or left anterior at the crux or things like that. At those particular areas, when it is sitting in the necrotic core, nodule can push through the cap, even if it is a thick cap. And in up to about 2 to 5% of cases of acute MIs, that could be the cause where calcification indeed leads to plaque rupture. So calcification is something which baffles you completely, but there are certain important things that we must realize, that whenever there is calcification, there is atherosclerosis, and you need to make your treatment more and more aggressive. Number two, at least you should do the test. If it is found to be positive, you know atherosclerosis is there. If it is negative, does not mean that you don't have atherosclerosis. Younger the person, women, it is less likely that you will have one-to-one relationship in those cases. 40 years old person, 50 years old person, 50 years old woman, you would never be able to say that if the calcium is negative, that means the person does not have an evidence of coronary artery disease here. And third important thing, you would have seen that there are multiple people who want to do yearly calcium score. And they say that I'm trying to see whether the disease is progressing or it is decreasing. So it doesn't mean anything. It doesn't mean anything, because if you are giving these statins to people, statins could cause it could cause an increase in the calcification, and it is not increasing your risk. It is in fact decreasing your risk. So I think calcium, we need to learn quite a lot. And then people who are on warfarin-like drugs versus certain other things which lead to changes in the calcification of the plaques. So there is a lot which we need to know and we don't. So we should go by very simple algorithms. If calcium is there, atherosclerosis is there. We don't have to repeat them, right? And absence of calcification does not mean that you don't have atherosclerosis.
I don't know if you're aware of this, but there are some people who believe that K2 deficiency, vitamin K2 deficiency, causes more calcification.
Right.
So you should have food and supplements which have K2 vitamin,
Right.
which will reduce your calcification.
But again, there's not much of evidence that we have. There are some animal experiments which prove that, but still, I think we need to learn a lot more about calcification, and that too, differentiating the calcification which is in media versus in intima. And that becomes a real problem when you talk about the peripheral artery disease, specifically infrapopliteal, where you can get the entire circumferential medial calcification, and that can indeed be responsible in absence of atherosclerosis, could even be responsible for critical limb ischemias.
Thank you. Any comment? Yeah, but I can tell you personal experience with the K2. Two of my friends, whose calcium score is about 2,500, 3,000, took and we repeated calcium, didn't decrease. But the K2 is the supplement which is available and people, it is marketed, that is going to melt down your calcium. But I have, two people, their own placebo, not placebo, it's a controlled trial. So they repeated 2 years later, they did not decrease, But something which, everybody wants to do something. When calcium is very high, it makes you nervous. And knowing with the guidelines, anything more than 400 put you onto the high risk. But anyway, this has been a fantastic morning, and thanks to our speakers and of course,